A patient sits in your chair, presenting with an acutely injected, painful eye. It looks severe, but visual appearance alone provides almost no actionable data. This generic red eye presentation obscures 12 distinctly different anatomical and systemic etiologies. Looking at this differential cluster, several of these are relatively benign, self-limiting issues. Conditions like dry eye, non-discharge viral or allergic conjunctivitis, and inflamed pungiculae require minimal intervention. But that same clinical presentation also includes acute angle closure glaucoma, scleritis, uveitis, and Kaposi sarcoma. To safely triage this list, you have to execute a structured physical pathway. The objective is to strip away superficial symptoms so you can isolate the precise anatomical layer of the inflammation. That stratification begins before you even look under magnification, simply by measuring the patient's baseline visual acuity. While a 12-point differential is dense, adhering to a layered, systematic workup will reliably rule out the noise and expose the true etiology. Treating a deep systemic condition with superficial drops often leads to vision loss. An accurate anatomical diagnosis determines if the eye's structure remains intact. This diagnostic flowchart outlines the required physical sequence. The first major step is the slit-lamp examination. We start by checking the superficial markers. A negative corneal stain rapidly eliminates infectious keratitis and severe surface desiccation. Next, you physically evert the lids. This mechanically rules out any retained foreign bodies acting as a physical irritant. You then evaluate the anterior chamber. If you observe inflammatory cells or flare here, the diagnosis shifts away from surface tissue and directly to uveitis. You must also check intraocular pressure to definitively rule out acute angle closure glaucoma. And finally, pupillary dilation is required to inspect a posterior segment for retinal involvement or secondary complications. Executing these steps systematically eliminates the observable mechanical, pressure-based, and infectious surface etiologies. Once the physical exam strips away those variables, you are left with the core diagnostic challenge, distinguishing episcleritis from scleritis. To differentiate between the two, you use a pharmacological provocation test, the installation of phenylephrine 2.5% eye drops. This test exploits a specific anatomical difference in vascular response. When the topical alpha agonist hits the tissue, it forces superficial capillaries to constrict, but it lacks the penetrative depth to affect the larger, deeper vessels. This diagram illustrates the two possible outcomes. In a case of episcleritis, the inflamed middle layer completely blanches. The redness vanishes, confirming the inflammation is purely superficial. Conversely, in a case of true scleritis, the superficial layers blanch, but the deep scleral vascular plexus remains actively injected and engorged. If that deep redness remains, the clinical stakes escalate. This requires a comprehensive investigation into the patient's systemic medical history. Scleritis is highly correlated with systemic autoimmune conditions like rheumatoid arthritis, lupus, and sarcoidosis, as well as infectious diseases like tuberculosis, syphilis, herpes zoster, and herpes simplex. It can also be drug-induced by medications like bisphosphonates or mitomycin, or emerge as a structural complication following trabeculectomy, cataract, or pterygium surgeries. Clinicians use the phenylephrine test to determine if a patient requires simple topical lubricants or immediate referral for systemic immunosuppression. If the diagnosis is simple sectorial episcleritis, the first-line management is supportive. Reassure the patient and prescribe ocular lubricants 4 times a day, alongside warm compresses for symptom relief. If the pain becomes intense, you escalate the protocol to topical NSAIDs or mild topical steroids, like FML 0.5%. However, you must warn patients against self-medicating with over-the-counter alpha agonist vasoconstrictors, like naphthalene, to temporarily clear the redness. This diagram shows exactly why. Sustained exposure downregulates the alpha receptors on the blood vessel walls. When the patient stops using the drops, the vessels lack receptor tone and violently dilate, worsening the red eye in a severe rebound effect. A more stubborn variant you will encounter is nodular episcleritis, characterized by a raised, localized area of active inflammation. This presentation requires careful patient education. You must set the expectation that nodular episcleritis takes significantly longer to resolve than the simple sectorial type. Because of its resilience, nodular episcleritis generally bypasses mild lubricants and requires an escalation to stronger topical therapy, specifically Pred Forte 1% used 4 times daily. Superficial red eyes can be managed topically, but allowing patients to use the wrong class of vasoconstrictor creates a frustrating, self-perpetuating cycle of inflammation. If your phenylephrine test confirmed scleritis, the management strategy changes. Topical eye drops lack the penetrative capacity to reach this depth of inflammation. As shown in this clinical matrix, you must prescribe oral prednisone at 60 mg 4 times a day, alongside an urgent referral to a rheumatologist to treat the underlying autoimmune or infectious driver. Similarly, if you diagnosed uveitis earlier in the anterior chamber workup, you must prescribe strong topical steroids like Pred Forte to suppress the internal inflammatory response. Uveitis management also dictates the use of cycloplegics, like tropicamide or atropine. This dilates the pupil to break posterior synechia and paralyzes the ciliary body to relieve the patient's deep, aching pain. But there is one specific clinical presentation of scleritis that is uniquely paradoxical and highly dangerous. It is a sclera that exhibits severe progressive thinning, yet shows absolutely no active signs of superficial inflammation or redness. Looking at this structural cross-section, you can see why this quiet but thin presentation carries a grim prognosis. The compromised ocular wall loses its tensile strength, putting the eye at risk of spontaneously rupturing under its own internal pressure. Evaluating a red eye requires isolating the depth of the inflammation. Differentiating the superficial episclera from the deep sclera is what prevents temporary discomfort from progressing to permanent structural failure.